First, let's set the scene by sharing a little about our trust. Somerset NHS Foundation Trust was formed in April 2020 from a merger of Taunton Somerset FT and Somerset Partnership FT. As such, we're the first NHS trust on the English mainland that combines community, mental health and acute hospital services. We have 1 district general hospital, 13 community hospitals, 7 minor injury units and around 800 inpatient beds. We employ around 9,000 staff.
Of course, as you would expect, given that we are here presenting to you, quality improvement is at the heart of how we deliver our services. And our improvement approach is underpinned by the quadruple aim from the IHI, which we have adapted to our local context. So let us share a little bit about the history of our team. 5 years ago, we were in a very different place. We'd been in financial turnaround where we'd been done to by repeated teams of external management consultants. Our internal improvement capacity was small, our processes were complex, and there was limited visibility of the change programmes that were going on across the trust. For instance, we identified 22 individual and unconnected projects that were seeking to improve the use of inpatient beds. Our turnaround experience was a wake-up call, and we were determined not to get into the same position again. The Trust Board knew that they needed to do something differently, and we had some suggestions.
From the outset, we were determined that our approach would be evidence-based. So we looked at the highest performing healthcare organisations globally and in the UK, and you'll see some of the organisations on this slide. We also looked to what research was telling us, and of course what our patients were telling us as well. We were particularly struck by Don Berwick's findings in his report on the NHS in August 2013, A Promise to Learn, A Commitment to Act, which highlighted the need for a culture of improvement and the need to build improvement capability. So in 2016, December, our board took the bold decision to make an unprecedented investment in creating a central improvement team, which underpins and supports improvement work across the trust. There were 3 primary drivers for this decision. Firstly, it allowed us to avoid the use of external consultancy and was in fact a cheaper alternative. Secondly, it meant that we could retain in-house the skills required for improvement rather than those skills remaining with the external consultants. And finally, it gave us the opportunity to raise the capability of the whole workforce in QI. Like many teams, our approach to improvement is based on the Institute for Healthcare Improvement Model for Improvement. We've structured the IHI methodology into a linear process. We did this iteratively using literally thousands of PDSA cycles and developing our approach based on feedback from our colleagues. The output is our 7 steps of improvement model. We found that this simple, linear and graphic 7 steps approach is extremely powerful and easy for teams to relate to and to follow. I think you will see in the graphic all of the steps that you would expect to see in an improvement approach, but the key is the linear approach which our teams have found so helpful and successful. In fact, the approach has been so successful that we are now using it as the roadmap for change across the Somerset system. It's been adopted as the core approach for our new integrated care system. Step 0 is people. It's so essential that we didn't even designate this as an explicit step. It's crucial that we ensure that we have patient service users with lived experience and colleague stakeholders involved at every stage of the process. Step 1. Understanding the problem is critical for success, although one of the least well evidence-based steps. We have found that pathway mapping, the 4 ends exercise, and use of the fishbone diagrams some of the most reliably useful tools. Step 2 is aim. We've simplified the process of creating an aim with a simple aim formula, comprising how much by when and other crucial elements. Step 3, measurement, fits into all elements of improvement, from understanding the problem to setting an aim to measuring the impact of PDSA cycles to outcomes. But to demystify the process of measurement, we chose to focus on it at step 3. Steps 4 and 5. We found that the term driver diagram was a little off-putting for some of our teams, so we refer to it as creating a plan. We find that this step dovetails into one workshop alongside with the next step, developing change ideas. Step 6, We've tried to refine the PDSA methodology to ensure focus on small, rapid PDSA cycles that maximise prediction and learning and create authentic buy-in from the coalface team. Step 7. Finally, sustain and spread. We've worked closely with the Southwest Academic Health Science Network and the Billions Institute from the USA to create a reliable approach to spread.
Sitting behind our 7 steps model, we have developed a blended improvement approach. This means that we have integrated benefits realisation and project management with quality improvement. Our benefits realisation approach is led by a specialist benefits improvement advisor team and helps us capture and assimilate outcome measures from the projects and helps us to understand the impact of this work for the whole organisation. For instance, reduction in length of stay may lead to increased number of patients cared for, reduced requirements for beds, reduction in waste, increased revenue.
An example of this is a bundle of enhanced recovery interventions that we introduced. This resulted in an average length of stay reduction of 0.4 days for our elective surgical patients, freeing up around 1,800 bed days per year. This means that patient experience is improved as they get better sooner and have to spend less time in hospital, and results in bed cost savings of around £410,000 a year. Another example is a project looking at outpatient follow-up appointments. By reassessing the value of repeat follow-up appointments and offering more patient-initiated follow-up appointments, we were able to reduce the waiting list by 27,000. This meant that there was increased capacity for first outpatient appointments, that our colleagues could spend more time with patients who really needed them, that patients had less expense, stress, time off work, and carbon emissions from unnecessary visits to the hospital. It generated a financial saving of approximately £4.2 million per year.
Benefits realisation captures the so what of our improvement projects. So what does it mean for our patients? What does that mean for our bed base? What does it mean for our waiting lists? What does it mean for carbon emissions? And what does it mean for our finances? This focus on benefits ensures that we are delivering value. Our ethos to benefits is that we are taxpayers too. Our project management approach ensures that we have robust and transparent oversight of our improvement projects. Our blended improvement approach is unique and has been designed by specialists within our team. To support our blended approach, we also have a blended team made up of a variety of specialisms. So, in addition to improvement advisors, we also have project managers and specialists, for example, in patient involvement, benefits, data, and communications. And of course, we have my own personal specialism, which is in using evidence and knowledge for quality improvement.
As a team and as a trust, we are committed to empowering and equipping people to improve from within. Raising the capability of the whole organisation and, of course, our patients is a key priority for us. We've progressed from the improvement team predominantly supporting projects ourselves to, in 2021, our improvement team will spend 20% of their time supporting projects and 80% of their time raising the capability of our colleagues to use improvement methodology to work through their own projects. We've developed a comprehensive training offer comprising bronze, silver and gold training, all firmly based on IHI methodology and open to anyone within our organisation, including patients and service users. Our training is experiential, which means to us that teams are expected to run a project and apply their learning as part of the training, with support from the improvement team as required. Training is an important part of raising capability, but by no means the only part. There are plenty of other offerings that we've decided to run to raise capability. For example, we run improvement grand rounds. You'll see some photographs from these on the slide. The grand rounds are a fantastic opportunity for frontline teams to showcase their improvement projects to their peers. These events have been phenomenally successful in allowing teams to celebrate their successes and their failures and allow others to learn from their experiences. We also run improvement drop-in surgeries where people can ask for advice and guidance from an improvement advisor. And finally, we offer improvement coaching support to all our bronze, silver and gold candidates routinely.
We are very proud of how far we have come, and this has been recognised internally and externally. We're especially proud of our Blue Plaque Award from the Academy of Fabulous Stuff that we received in November 2020. This recognised our authentic commitment to quality improvement and the fact that we have embedded improvement in the DNA of the organisation. We have shared our learning with colleagues across the country and internationally by welcoming teams to come and visit us and presenting our story at external events. Pre-COVID, we ran a successful showcase event, which was a face-to-face all-day event attended by system partners and with a keynote from Roy Lilly. We are currently developing our next programme of virtual events, which will be called Let's Talk QI and will launch in the autumn. None of this would have been possible without the support of our peers. We're especially grateful to colleagues from East London NHSFT and Dr. Ruth Brill from Tees, Esk and Wear Valleys NHSFT, who may not realise how much they have helped inform our approach and culture. We would also like to thank colleagues from the IHI and South West Academic Health Science Network for their support and mentorship throughout our journey. So what next for our team? Like many of you, we are constantly changing and evolving. Having completed our recent merger last year, we are now in the throes of another merger with Yeovil District Hospital. Like you all, we are transforming our services to work as a part of an integrated care system. For us, this means developing a Somerset collaboration hub and working more closely with our system partners, including our county council and primary care colleagues. We're delighted that the collaboration hub will use the 7 steps methodology we've presented here today, so that we will have a single improvement approach for Somerset. Working as part of a wider system is also requiring us to think differently and evolve our terminology as we think about services more holistically. For example, we have had to change our mindset from thinking about patients in acute care to thinking about service users or clients in mental health and community services to now thinking about citizens in an ICS.
Before we conclude, we wanted to share our top 3 pieces of learning with you, and we'd love to hear in the Q&A whether these resonate with you. Firstly, we've found that focusing on capability raising is important. Sustainable quality improvement needs to come from within, so investing in the capability of the wider organisation will pay dividends, and has for us. Secondly, executive support is crucial. We couldn't have done what we've done without the authentic, practical and financial support of our board. We advise you to invest the time up front in getting them all on board. It led to a hefty coffee bill for me, but it was definitely worth it. Finally, keep it simple. Make QI simple for teams to engage with. Keep things short. Avoid jargon and don't let QI become a clique. We found that by focusing on our 7 steps model approach, we've been able to demystify QI, and this has allowed everyone to own it and engage with it. The easy to use nature has had incredible impact and traction. So in conclusion, in this session we've introduced you to Somerset NHSFT and shared with you our 7-step approach, our blended methodology, and how this is underpinned by investment in training and capability. And finally, we shared with you our learning. We'd be delighted to take any questions in the Q&A session. Thank you for listening.
Thank you to Amy, Anne, Andrea and Mike for really powerful presentations on our blended and new approach to QI. Keeping it simple, 7 steps, using the virtual. We have really been inspired by your presentations this morning. Thank you. I'm going to pick out 1 or 2 questions from the chat box. There's lots of conversation going on, and thank you for that. I'd like to start by asking, by pointing out to you that Andrea and Mike have included their contact details for follow-up, and also Amy and Andrea and Anne are just about to do that. So thank you for that. So David Meehan, thank you for your question. You're asking us where we don't have access to tools to join a virtual space, how do you get around that? In terms of the big room presentation, Amy Ann, anything you'd like to respond to on that basis?
Sorry, I slightly missed that. Can you repeat that? Sorry.
Sorry, apologies. It's where people don't have virtual access. How do you connect them with the tools and the resources? What tips have you got?
Yeah, I saw the comment about kind of digital poverty, and I think it's a really good question, and it keeps on, challenging our approaches for how we work with our women. I suppose for us, it's about, I think we believe that, going virtually has made it more inclusive. So we do think it's one step forward. Granted, I don't think it's perfect. We're still not reaching everyone by any means. But for us, I think it's to do with linking into local community groups. So we work really closely with our maternity voice partnerships and work with women through that to think about how we're building our services and what we need to offer them. So for us, that's key. But I really acknowledge there's kind of like more that needs to be done in terms of that equity and reaching our kind of diverse populations that we have.
I see a related question coming on. Does the virtual space impact the number of staff and clinicians who attended?
So I'll take that. So yes, in essence, because when we started the Sepsis Big Room, it functioned on one of our sites, and it was really difficult to engage our other sites and to bring other teams in. And when we moved to the virtual space, we involved all 3 of our sites and many more of the teams. And we went from attendance of 20 to 25 people to an attendance of 50 to 60 on some days.
Interesting. And then particularly, how did you get the mums to engage in the big room? Anything that you supported mums with?
Yeah, I mean, the big room's built on kind of like also fantastic clinical leaders who, really want mums to be involved. And so they're incredibly good at having conversations with women when they use our services and inviting them to attend. So it's building that relationship as they access our service. But also it's the local groups, so it's the maternity voice partnerships as well, and constantly offering or inviting the women to come, and really hope that they do.
Thank you. And can I move topic now? And Andrea and Mike, I see lots of comments in the box about the blended approach and how brilliant that is. I also see comments in terms of others who've struggled in terms of getting that going. Have you any suggestions or tips to others who might like to start a similar journey?
Thanks, Maureen, very much indeed. And Amy and Anne, found your presentation really inspiring. Loads of comments about the digital poverty as well, which affect us in terms of our training and training people who are suffering digital poverty. So, I can't answer that now, but we certainly, it's not an isolated problem. So Maureen, for people who are struggling to sort of get that going, I recommend stealing. It's always more powerful when you've developed something for yourself in terms of having that emotional buy-in to the content. But we are absolutely 1000% happy to share anything we've developed. And people are very welcome to come and join our new virtual sessions that we'll be running as of, I think, August, September. So please do come along and learn, and just steal shamelessly. It's, anything I've developed or we've developed has been very much copied from the IHI, so it's not novel. It's just there's a massive emphasis on simplicity and paring it back so that teams are able to do it themselves without feeling like it's special or difficult. So come and steal would be my biggest tip. Andrea, I don't know if you've got anything to add.
Absolutely, Mike. I couldn't agree more. Use evidence, use best practice, learn from others, share what you're doing. We try to take a lead in championing that, working together with the key community, the Academy of Fabulous staff, the AHSMs. So it's very much part of our ethos to ensure that we're evidence-based in everything that we do.
Thank you so much, Andrea. And there's a particular question about convincing people of the value of QI above audit. Any thoughts on that?
So we made a really explicit step at the beginning to have a medical lead for the QI function, which is me, obviously, because we felt that the doctors might be one of the hardest groups to tackle. We explicitly at the beginning tried to spread our QI offer so that it was very equal across the whole of the hospital and not just focused on doctors who may be difficult to convince. And we included our patients and service users in that training as well. I would say it's not been at all difficult to engage doctors and other members of staff in the value of QI over audit. It's been much, much less difficult than I'd anticipated. It feels like people feel that audit is rather static. It absolutely has its function in terms of compliance and regulation. And it's an incredibly useful tool for validating the quality of services. But in terms of change and improvement of services, we've had really no problem in persuading people of the value. I think part of that, though, is back to the comment we've made very heavily in the presentation, is around the authentic executive buy-in. So that our executive team talk the language of QI and model the behaviour of QI just about in every meeting they go into. And I think that opens the door.
Great. Thank you very much, Mike. And I see that links into a further question. Unfortunately, we won't have time to, but getting your board on board, which is obviously hugely important in supporting QI. Regrettably, our time together is running out. Thank you to Anne, Amy, Andrea, and Mike. On behalf of the fabulous 235 participants we've had at this morning's session, I see a continuing conversation and connections, which is really super. So hope you have a quick, enjoyable tea break and look forward to our next sessions, which are starting at 11 this morning. Thank you, everybody.
Thanks, Maureen.
Thank you. Thanks, everyone.